Good afternoon, everyone, and welcome. My name is Kelsey Goforth, and I'm Dying with Dignity Canada's Director of Programs, and I'm joined today by two of my colleagues, Kat and Amanda. Today, I'm speaking to you from Ontario, from Toronto, and I'm speaking to you from the traditional territory of many nations, including the Wendat, Haudenosaunee, Anishinaabe, and the Mississaugas of the Credit, located in Toronto and covered by Treaty 13. I acknowledge the legacy of colonialism and the impact it has had on all areas of life for Indigenous peoples, including healthcare. As part of DWDC's adherence to the values of inclusion and people-centeredness, we're committed to working towards recognizing, respecting, and addressing the distinct health needs of Métis, Inuit, First Nations, and Indigenous peoples related to end-of-life and medical assistance in dying. We will continue to work to listen to and amplify the voices of Indigenous communities in the discussion of end-of-life choice. I'm thrilled to welcome you to our session today. This is the next session of our Regional Spotlight, where we provide you with information about MAID and end-of-life care in various provinces throughout the country. And we are making our way west and are now focusing on the province of Alberta. So before I welcome today's presenters, I would like to go over a few housekeeping items with you. Everybody who is joining us today on the call is muted. However, there will be opportunities to submit your questions. To do so, please type your questions into the question bar on the Zoom side panel, and we'll read it out for you at the end. And please do try to keep your question as concise and clear as possible so we can get to as many as we can this afternoon. While we will try to get to everybody's questions, unfortunately, we might not be able to. So if we don't get to you, or if you do have a question that's more personal in nature, please contact us at support@dyingwithdignity.ca, and we will follow up with you individually. We're also going to have a survey pop up on your screen as we wrap up today. And if you could take a few minutes to share your feedback with us, that would be very much appreciated. We are also recording our session today, so if you miss it or you have a friend or loved one who might be interested, it will be posted on our website. Now, we will introduce today's speakers. Firstly, we have Peter Godor, who has been a critical care nurse practitioner in Edmonton, Alberta for the last 2 decades, working in a tertiary intensive care unit and rotary aeromedical transport. An active MAID assessor and provider since 2016 for the Edmonton, North, and Central zones of Alberta, Peter is involved in multiple initiatives both locally and abroad for the advancement of MAID delivery. Thank you for joining us, Peter. And joining us, we have Dr. Hayden Rubensohn, who is a palliative care and internal medicine physician. This career has exposed him to all manner of end-of-life journeys and has provided a deep knowledge of the importance of decision-making at that delicate time. Hayden is an ardent believer in patient autonomy around end-of-life choice and has been a MAID assessor and provider since March 2021. Hayden is keen to participate in advocacy related to enhanced MAID access, and as a DWDC board member, is thrilled to work with and learn from the DWDC board. When Hayden is not providing patient care or having advanced care planning discussions around the dinner table, he is usually on the ski hill or on his bike alongside his wife and 2 young boys. So thank you both for joining us today. I'm going to pass it along to Kat to get us started with the interview.
Hello, everybody. My name is Kat, and I'm the program specialist at DWDC, and I will be doing the Q&A portion and interview questions today. Thank you so much for joining us. So to get started, what inspired you both to enter into this field? And maybe Peter, we'll start with you.
Sure. Thanks for having me, by the way. It's an honor and privilege to be able to speak in front of all interested people. What got me interested in this field was really my critical care work. I've long before medical assistance in dying was available, I've noticed and lived it that we don't do death very well in critical care and in general. And once medical assistance in dying was available and there was a need for more providers and assessors, I felt that this was partially my calling to to be involved and bring that to my critical care area, and maybe bring a little bit of critical care to medical assistants in dying as well.
Thank you so much for sharing about yourself and what made you enter into this field. How about you, Hayden?
Excuse me. Yeah, I also just want to start off by saying thank you for the opportunity to be here and to speak on behalf of our province and present some information. You know, I get a little bit unsure if I should give my true answer about this, because my dad is a veterinarian. And so I, of course, recognize that people are not pets or animals, but, you know, the existence of euthanasia in veterinary medicine has been around forever. And so, you know, this notion of that is how death is approached in veterinary medicine has sparked conversations in my family for honestly as long as I can remember. And so we've had forever discussions in my household about what does it mean to die with dignity? What does it mean to, you know, focus on autonomy and patient-centered care right until end of life? And what does suffering look like? And who gets to determine what suffering is? So really, I mean, this notion of medically assisted dying has just been a part of how I saw the world and how I understood death and dying to be for the entirety of my life. And so really, it coming into fruition, there was never really a question of will I be involved? It was more just a matter of when will this exist so I could be involved. But, you know, again, my career is palliative care and internal medicine. So very much through the work that I do, death is front and center. And so really this was a continuation and an additional, I guess, tool or skill set really to add on to my medical practice.
Thank you for that. And I think that kind of goes into my next question about how wondering, is death something that's commonly or openly talked about within the community? I know you mentioned veterinary medicine, and that's definitely something that I think people across Canada and the world know very much about, but MAID is kind of a little bit more taboo. So in your experience, is it something is death commonly spoken about within your community?
You know, I find this such a surprising dichotomy. You know, there's these people who I work with that say, you know, the stigma is falling away, the knowledge is getting out of there. They say, not only am I aware of MAID, but actually a close friend of mine had it, or I was in the room when a close family member received an assisted death. So in that way, like it's sort of proliferating, the knowledge is getting out of there. And then I'm absolutely flabbergasted by the number of people I meet who have advanced illnesses that just say things like, I just never imagined myself dying, and haven't spoken about it. So I think it's a little bit tough for me to really evaluate the community, because when I'm with my palliative care colleagues, it's, it's something we talk about and it's part of the work we do. But fortunately, I think word is getting out. But, you know, the notion of like death cafes where people go out and talk about it, the notion of different community groups putting on like a facilitated death discussion type of evening or estate planning. I think there's a lot of room for things like that to keep talking about it and normalizing that we're all going to die at some point.
Right, very true. I think you said it best, normalizing death and talking about it as if it is a regular conversation, because death is inevitable, right? Peter, how about you?
No, absolutely. I can only echo what Hayden said, that there's such a split between people being aware and having participated, having first-degree relatives that have gone through MAID, or they have been involved in someone's care who is going through MAID. And at the same time, again, just like Hayden, I have discussions with patients and families, usually the families, of elderly, frail individuals with multimorbidity that are in their 80s and 90s. And when I have the family conference with them or with their loved ones to try to set some goals for their care in the ICU, as in figuring out just what level of care, what goals of care they have. And sometimes and oftentimes the responses are shocking. They never thought that grandpa is going to have this discussion about end of life care, and grandpa has been in a nursing home debilitated for a decade, or have advanced cancer, or have advanced cardiovascular disease, or they have been on dialysis for 5 years. So it's really, when you say the words community, I'm not exactly sure which community you're talking about. Community in the ICU, community in healthcare, or colleagues, or Canada in general. There's definitely room to grow, but I also see how far we've come in the last 7 years. It is normalizing it, and hopefully it continues on growing. And looking at the numbers, which we'll chat about later, it certainly does reflect that growth and advancement.
And on that note, you mentioned that the outlook of death and dying has changed dramatically in the past 7 years, but how about the last 5 to 10 years? Do you have anything to say on how death and dying has changed?
Yeah, probably Hayden is probably better able to chat about palliative care especially, but what I've seen in my humble perspective, and granted, prior to me becoming involved in MAID, I haven't had a lot to do with palliative care per se, like formalized palliative care, although certainly we palliate a lot of individuals in ICU. But what I hear from colleagues and those that are involved in palliative care, certainly that even palliative care has evolved a great deal over the last couple of years, not alone over the last couple of decades. In fact, there may be, and Hayden, feel free to correct me, a lot of the push for medical assistance in dying was because we did palliation not that well before.
Yeah, so I mean, I think over the last 5 to 10 years, I've seen a lot of changes. You know, there's been so many, I guess, from the standpoint of medical education, there's been so many workshops on communication skills and palliative care lectures. Increasingly, palliative care clinical experiences are becoming mandatory. So there's an increasing awareness amongst medical providers about what palliative care is. Now, that doesn't mean all of them are able to provide high quality palliative care. They may just not have time or resources in their practice, but at least they're familiar with the concept of a palliative approach to care, which then means they get resources and other services like my own involved. So, we're seeing earlier palliative care in places like the ICU, on surgical services with advanced organ dysfunction and system multi-organ failure. So I think there is an increasing acceptance and understanding that somebody dying or who's incurable or getting worse is not a failure of medicine anymore. It's a physiologic reality. And I think that has allowed for greater discussions and preparedness in the medical community around palliative care and end of life. It's been interesting to see some of the shifts with respect to MAID. Just as a local example, in Calgary, the Foothills Medical Center has historically had a limited number of people doing MAID assessments on site. It's just sort of a quirk of Calgary where the other hospitals have a group of assessors and Foothills has not. And so really it was sort of myself and one other hospitalist who was doing the bulk of MAID assessments. And in the last 4 months, we've had 4 new palliative care providers sign up to do MAID assessments at Foothills. So we're certainly seeing a shift in palliative care, but also that, you know, what I can say is that adversity, that butting of heads between palliative care and MAID that I think existed in 2016 seems to be diminishing. Like my experience is that palliative care and MAID have a much more amicable relationship. We've certainly seen in Alberta plenty of funding go to palliative care, and so we know that it's not really one or the other. We actually have, I think, a fairly robust MAID program as well as high quality palliative care. And another major change that I've seen over the last several years has been, as we talk about MAID being normalized and death being normalized, the stigma about introducing MAID as an option seems to have gone away. So it used to be, you know, people would say, oh, well, you can only talk about MAID if someone brings it up first. And over time, at least amongst medical providers, and Peter, I don't know if it's the same for in nursing, but now we say that you know, you're not really providing informed consent and truly telling people their options if you don't inquire about their knowledge of MAID and if that's something they want. So that has also become a bit more routine. And we've learned how to ask people if they know about and are interested in MAID without sort of making it feel forced. So I think there's been a lot of changes in the last few years.
Thank you for that. And thank you both for the valuable input. I think basically what I'm understanding is there's been a great positive change in the way that we're speaking about death and dying now. And you kind of touched a little bit about MAID, and I think that's a good segue into speaking a little bit more about MAID. So on the topic of MAID, do either of you have any information on the number of MAID deaths in Alberta?
We do. Peter, I know you went through the report, so do you want to pick out what you found?
Sure. I'm not sure if you just want to hear about just Alberta or in context with Canada. I'm just going to tell you both and maybe throw in some of the other provinces as well. So we have had the fourth annual report from the Government of Canada reviewing all of MAID, and that was actually released exactly a year ago. And that included all the numbers up until the end of 2022. So these numbers are a year old now, but still very relevant, and we can extrapolate onto it, and I will do that. So as of the end of last year, so a year ago this month, in Canada, we had 45,000 completed MAID events, and Alberta, we had 3,000. And we can extrapolate from that by now we probably had just over 4,000 completed medical assistance in dying cases. How that fares in percentages. So in Alberta, in 2022, about 2.6% of people that died chose to go through medical assistance in dying. And again, we're faring fairly, you know, at the bottom three provinces. Only Saskatchewan and Manitoba score lower than us, Manitoba being very low at 1.8%. And then on the other end of the spectrum is we have Quebec and British Columbia. And Quebec is at 6.6% of patients who die choose to go through medical assistance in dying, with closely followed by British Columbia, 5.5%. Yeah, and then we have all these little pockets of Canada that even higher, such as Vancouver Island, that almost 10% of people that die choose medical assistance in dying.
Thank you so much for that. Very, it's interesting to see that Alberta is so low in terms of all of the other provinces. My next question is, what are some common misconceptions about the MAID process? Maybe Hayden, if you'd like to take this one.
Yeah, probably um, the number one misconception seems to be about the speed of the process for getting MAID approved. And again, it seems to kind of be this dichotomy where there's some people who believe that, they say today I want MAID tomorrow, and it's like, okay, we'll go ahead tomorrow. There's this misconception that it is, you demand it and it's ready and available. So not really being aware that there actually is a fairly involved administrative process with the 2 assessments and the need to actually plan a provision, organize support nursing, organize prescriptions. We do have, a very effective MAID coordination center, but again, depending on availability of assessors and support and availability of meds. I mean, there was one time we got a MAID, from application to provision in under 24 hours, but that is like by far and away the exception. So we tend to quote people that they need to budget 2 to 4 weeks to get their 2 assessments done, based on, again, how many assessments are needing to be done, province-wide or certainly within that zone, and how many assessors are available. I will say on the flip side, I've had a few patients who were under the impression that the process was actually inordinately long. Like one woman told me she thought, oh, you had to petition the court and it would take several years to get judge approval. And so she thought, well, what's the point of me applying for MAID? I don't have that much time. So while I think there has been excellent sort of dissemination of knowledge that MAID exists and is available, because I've run into fewer and fewer people who say, oh no, I didn't even know it exists, or I thought that was illegal. More people tend to be aware of it now, but there hasn't been as great dissemination of the knowledge of how to actually go through the process and what that process looks like.
Thank you for that. We also definitely get a lot of questions about the time frame as well, and it can be different depending on how many assessors are available, where you live, a lot of different factors.
Yeah, there's an interesting quirk where, like, I work in Red Deer, and in Red Deer we almost are able to get 2 assessments done more quickly because there's about 5 people that do the assessments, and we all know each other. So we, if I get a request, I can just text the others and say, hey, anyone available? And we sort of figure it out ourselves. But so it's almost like within Red Deer, even though it's more, it's urban, but it's also rural. We can actually sort of get things done faster than in Calgary. But I think it is just the smallness of the group there.
Sounds very efficient.
Yeah.
I would love a group like that.
Yeah.
Peter, I don't know if you have any input on.
Yeah, no, definitely the regional differences. I think the best example for that is that just like you guys in Calgary, Hayden, here, I've been involved in now 2 cases where we were able to squeeze out application to provision on the same day, and they were by far the exception. And they were, everything just fell into place. We had 2 available assessors. The patient was in horrific pain, and it was those classic case where someone just fell between the cracks. But anyway, we squeezed it out, and pharmacy or community pharmacy was ready with medications. One of our community pharmacies has medication packages on standby. So all these things helped, but by far, usually even in the city, ideally we squeeze out application to soonest provision in 4 or 5 days. And that's a good, fast service. And again, once you move into the rural parts of Alberta, and I do some assessments and provisions for the central zone, which is between Red Deer and Edmonton. So in that, and spans all the way to the Saskatchewan border and almost to the BC border. Sometimes people have to unfortunately wait weeks, even just for an assessment. And for example, the central zone, it's pretty much, there's just one other assessor provider and myself that do, because every single assessment or provisions that I do, the other assessor or the provider, if I'm just assessing, is that other physician. So it really varies as far as the availability of providers. And sometimes I have to travel as far as Hannah. I'm not sure if you guys know Alberta, but it's like 3-4 hours of drive from Edmonton.
Oh, wow. Okay, so you're very committed to your work, it sounds like.
I wanted to touch upon one more quick point of what Hayden said earlier about palliative care physicians and the nurses and service kind of coming around to having it less of an adversary relationship with MAID. And that's when MAID became available first in 2016. I was part of the initial rollout and disseminating information and having lunch and learns and education. I did a lunch and learn session for the palliative service at the Royal Alex Hospital, which is where I work. And the palliative docs came, the palliative nurses came. I'm not pointing out one or the other because they all behaved equally the same manner, and they came for a fight. They had questions. They wanted to know how dare we. It was probably the most heated exchange I've ever had in my career or even in my life. And I have done these sessions ever since then, and that has completely gone away. In fact, so many of our referrals, our consults, the questions, the requests for talking to patients, even curbside, come from palliative care now. I have honestly, Hayden, if you were to look at my Connect Care secure chat messages, half of them are the palliative care service asking if I could swing by and explain something to this family or this patient. So the progress of the relationship between palliative care and MAID has, and in fact, we now have multiple providers and assessors that are palliative care physicians. So.
Yeah, I'm glad to hear that you've seen that play out, because I feel like that area of medicine, palliative care, has really gone through an evolution through that. And Alberta specific point, for I don't know where all of our audience members are from, but for those from Alberta and specifically if anyone's from Red Deer or Central Zone, we actually just had a huge success in Central Zone where the Red Deer Hospice was the only standalone hospice that was not offering MAID on site. Now, and the important thing there is it's not affiliated with any faith-based body, so any facility that's faith-based, they don't allow MAID, but Red Deer was not. Red Deer was secular and was not allowing MAID because of this sort of tenuous relationship between palliative care and MAID. And we were invited as a group of Central Zone doctors and MAID involved people to discuss this and provide some education. And there was a unanimous decision by the board of the Red Deer Hospice Society to allow MAID on site as of, I believe, November of last year. So it was a huge gain for the community. It was creating a lot of tension for patients who found themselves in hospice or trying to make decisions about hospice and who were in Red Deer Central Zones. So yeah, a lot of positive forward movement.
Yeah, that's amazing. We love to see that.
Yeah.
So thank you. Okay, let's switch gears just a little bit. Have either of you received feedback from individuals who experienced a MAID death about what they found helpful or unhelpful as they navigated their grief? Maybe Peter or Hayden.
Yeah, I'd be curious to hear what Peter has to say. I mean, I will admit that my involvement often stops after the provision. There's sort of a standard grief package that is provided. I have not personally been contacted except in one case where the patient who received MAID was quite young, and I had been in email contact with her partner, and just reached out several months later to see how he was doing. It was quite an impactful case, and he had a lot of positive reflection. And grief is a hard thing and takes a while to sort of move through and navigate, but he had very positive reflections on the type of death that she had received. And so again, it was less about providing resources and more about checking in, but generally, admittedly, my involvement kind of ends at the provision. So
yeah, that's a great question. And again, we need to remember that we may be involved in the provision, and our involvement usually stops there. But family members that attend and just are connected to that individual, that the grief goes on, and that they remember this for the rest of their lives, for many decades to come. So we do need to make sure that we address that. Now, I have to be honest, and I kind of had heads up that this question may come up. So I did ask, I did talk to our navigation team, and so grief counseling and preparing the family for what happens after the provision starts with the MAID navigators. So the MAID navigators do address this with the family and the patient, and they make sure that it is addressed, and they do get contacts. Just like Hayden, myself, I've never been contacted regarding grief counseling after effect. But certainly the navigation team does get some inquiries, and they do follow up with them and direct them to Alberta Health Services grief counseling available resources. Now, as far as for my practice, and obviously, you all know that provisions can take place both in hospitals and healthcare settings, and they can take place at home. And so when the provision takes place in a hospital, then, as Hayden mentioned, there's a standard Alberta Health Services grief package that is provided to the patient's family as routine practice. And that is, I have looked at that package. It's very involved and very detailed as to how to receive grief counseling, and it's very multi-denominational, and as well as very respectful of Indigenous culture and available resources to them specifically. And myself, for my own practice, when the provision takes place in a home or away from a healthcare setting, then I direct them to the Dying with Dignity Canada website, and they can access grief counseling through that. Again, I've never had direct feedback, but from what I hear from the navigators is that the overwhelming feedback is positive.
That's really great to hear, and also very helpful that the navigation team helps folks out with grief and dealing with very mixed emotions sometimes surrounding death. So thank you for that. On the note of dealing with grief and kind of talking about our feelings surrounding death, are death doulas commonly contacted for supporting folks through death, dying, grieving, and healing in your region?
Yeah, death doulas are only something I've read about, but I've never encountered one or a family who was working with one. It seems like much more of the support is generally coming from family, sometimes clergy or a sort of spiritual community. And then, so as Peter's saying, in certain cases where more support is needed, other professional bodies.
I had one case where a death doula was attending. I loved it. Like I really did. It was great. I'm definitely 100% supportive of that. I would like to see more. And it doesn't have to be a formal death doula, like Hayden said. I have had in other cases, in fact, just yesterday, where clergy elected to attend, and that actually warmed my heart. That I felt that was that's also a reflection on not just palliative care physicians and palliative care services coming around to accepting medical assistance in dying, but certainly the religious community.
Yeah, if I can piggyback on that, Peter, I had actually like a very memorable experience with a man who was Indigenous and very strongly connected to his Indigenous practice. He was suffering greatly, and when he learned that MAID was an option, I mean, he just, why did no one tell me sooner? And really requested that. But in the days leading up to his MAID provision, the hospital was able to sort of deactivate the fire alarm in his room, and he had an elder come in and do some smudging ceremonies. And the elder was, both very supportive of this man pursuing MAID and talking about how, he would still be able to go to the spirit world and, connect with his ancestors. And I just love that the hospital found a way to support that practice in his own hospital room. And so right before the provision, again, he had a smudging ceremony, his elder was there, and then I was able to provide MAID. So yeah, that was quite memorable.
That's a really great memory to have. And just the fact that we're able to give, well, you specifically and you as well, Peter, individuals with different spiritualities and beliefs, the opportunity to connect with where they come from, their roots, their beliefs in a manner that is respectful. And that's really great to hear. So thank you for sharing that. And on the topic of grief, and we do a lot of speaking about how we can support those who are going through a MAID death and those who have passed away from a MAID death. But of course, grief comes from death and dying, but of course, we experience grief as people that support people who are in the process of dying. So do you experience grief in your work, and how do you navigate this, particularly after the death of a patient?
This question kind of reminds me of, when I do palliative care, it reminds me of when family members say, I don't know how you do this work, isn't it so sad? And, I will always remember my ICU rotations in training. My ICU rotations gave me nightmares. And honestly, like some of the most difficult to deal with death were these deaths in the ICU. There was like little ceremony, there was little focus on dignity and personhood. So I often tell people, I don't find palliative care sad. I mean, of course, there is a thread of sadness in the fact that people are going through loss, but what we focus on is dignity, humanity, personhood, the stories, the memories. And so I find that my work is actually incredibly uplifting because of what we choose to focus on. And so I admittedly, the first MAID provision I ever watched, I cried the whole way through. But what it's now, it's reached the point where it is provides a moment to pause and reflect. And I find for myself, rather than sitting in a place of grief, I sit in a place of reflection, and it really just helps me take stock of my own life and focus on gratitude for what I have, and know that this will end at some point. I will die, my loved ones will die, but what do I learn from the families I work with, and how do I take from that experience so that I can live better now? So yeah, as I say, there is always that thread of sadness, but there's so much more to the experience.
Definitely a learning curve, and it's great that you're able to kind of take something that's so sad, people see as so sad, and kind of switch it and give it a positive look. How about you, Peter? Do you experience grief in your work, and how do you navigate it?
Yeah, so I'm a little upset at Hayden for taking my ICU thunder away, but clearly Hayden remembers his ICU rotation as a resident. So, right. So we get this question all the time. Usually the question is, how can you do this? Like, does it wear you down? Does it, do you carry that burden? And again, exactly, I'm just going to parrot Hayden. In ICU, we see so much suffering and pain, and sometimes it's needless, and sometimes it's needed. Sometimes it's invited by the patient. The patient wants this. Sometimes they have no choice because family wants it. But regardless, there's so much pain and suffering happens in ICU despite our best efforts that in fact, that is, like I said, that is why I started doing MAID. And I feel like this is my way of giving back a little bit and gaining my soul back a little bit for all the pain and suffering that I've taken part. And in fact, I caused some of that with procedures and extending life when it was futile. So I can honestly say, with no pun intended, no hyperbole, that of all the things that keep me up at night, medical assistance in dying is not one of them.
That was very, very well said and very powerful.
I know it sounds like a canned response, but it is.
No, that's a great response. I'm speechless. I mean, I think that is such a great outlook to have, and you wanting to give back to the community that you serve is just honorable. So thank you both for your comments. Wow, that was a lot. I think we're gonna change gears a little bit, and we're going to go to some of the registration and audience Q&A now. So we have quite a bit. So everybody, if we don't get through to your question, feel free to email us. Maybe Amanda or Kelsey, you can put the email at the bottom if your question is personal in nature, and support will get back to you. So our first question from the registration and audience Q&A is, how can non-clinicians in the healthcare space, such as RNs or social workers, help to support patients considering or pursuing MAID?
Yeah, I think that some of it is guided by their individual colleges. I believe there are certain colleges that still do abide by the rule that you can't talk about it unless a patient brings it up first. But certainly if a patient does bring it up, then being able to speak about MAID with no stigma as just a way of, a normal conversation to have. There's a discussion about MAID or a wish to die statement is always a great opportunity to explore what suffering means to a person, which then gives the chance to sort of validate that experience. And from a very pragmatic standpoint, we still need people to witness records of request. We still need people to act as proxies in the setting when somebody cannot physically sign the paper. They still have to have mental capacity, but if they cannot physically sign, then a proxy can sign on their behalf. So, anyone who identifies and tells maybe their manager or charge nurse and says, hey, if you hear that someone wants to apply for MAID, I'll self-identify as, being willing to act as a witness or a proxy, that can be really helpful.
That's very, very true. So thank you for that. I think for the sake of time, I think we might do one question for each of you, just so we can get through as many questions as we can. So Peter, are Are you aware of any universities or colleges in Alberta that teach MAID to medical students?
Well, this would be a question for Hayden. I know that there's more and more focus is on that. Just having physician friends, I know that it is becoming more and more part of the residency exposure at minimum. I'm not sure about Hayden could probably speak to that better.
Yeah, you know, I admittedly I'm not involved with sort of curriculum development. I actually have very little involved with the medical student level of teaching and more so with the residents. But certainly at the resident level, it's becoming more common. Certainly, as part of the palliative care training, there will be a mandatory lecture on MAID. Now, that's not how to do it and saying like you as a provider will be or should be doing it, but certainly you as a palliative care provider need to understand the mechanics and understanding of what MAID is because your patient's going to ask. So, yeah, hopefully that helps.
Yeah, definitely. Peter?
Yes, and at the same time, it popped into my mind that, however, nursing school, undergrad nursing school, and nurse practitioner school is now have. In fact, I've given multiple guest lecture sessions on medical assistance in dying, so it is part of that curriculum. And again, it goes back all the way what we were talking about at the very beginning, that the things are changing slowly. And to speak to the other question that you had earlier for Hayden about regulatory bodies, both the college for the physicians and to the nurses and nurse practitioners, their position statements and their if you will, the rules and regulations and practice guidelines have changed over the last 7 years, and they have went from that very restricted, don't talk about MAID unless you're being asked, to all the way now it is part of your responsibility and privilege to talk about MAID as part of end-of-life discussions. And just again, with everything, we have to remember that when we talk to patients about anything, just have to make sure that the information you're giving is correct and that it is your role to do that. Clearly, a nursing student should not be explaining to a patient about the new MRI results of their brain that they just had, and the physician hasn't had, or the nurse practitioner hasn't had a chance to discuss. So same with medical assistance in dying. You are free to discuss topics that is within your scope and within your knowledge base.
I think those are very good points to consider. So thank you for that. Our next audience question, for either of you, whoever would like to answer this, the audience member says, I currently volunteer for Bridge C14, which provides emotional support for people considering or pursuing a request for MAID. Can you see a future in which the Alberta Health Services provides this kind of support alongside assessments and provisions? For example, could the Alberta Health Service formally include death doulas into the healthcare team?
Hayden, this is all yours.
Oh, I mean, it's a tough question. Like, I mean, I think from a health economic standpoint, Alberta Health Services will do anything they can to not have to pay any additional people to help. So is there a role? I mean, that whole grief and bereavement piece is, I think, yeah, it's all too often an afterthought when whether it's palliative care, oncology care, or MAID. It's almost like we take care of the patient, but once the patient has died, it's kind of like the health authorities' duty falls off, and which is why, thank goodness, we have organizations like Bridge C14 and Dying with Dignity Canada. But yeah, I mean, we are a healthcare system that's driven by diagnosis. So of course, if you come out of a MAID experience with, complex bereavement and psychological issues which are diagnosable, you should be able to get connected with mental health resources, but as sort of an enduring support, like again, when you're not diagnosable but you need more support, it's unfortunately my knowledge is that in Canada that tends to fall into a category of where you either get it through work with like an EFAP kind of program, or you pay for it out of pocket. So I would love to see more support, but I don't see Alberta Health Services sort of leading the charge on it.
Right. It can be really difficult. And we do have some information about recommendations through Dying with Dignity Canada. So if anybody is ever looking for support, you can email us at support@dyingwithdignity.ca and we can help you with that too. This question is for Peter. Is the Sherwood Park area included in your boundary of practice?
Yes.
Okay, wonderful. Thank you for that. And a question for Hayden. Hayden, you previously commented on a current initiative by the College of Physicians and Surgeons of Alberta to remove effective referrals in their guidelines to their members. Why is this happening? An audience.
To be honest, I've only sort of followed it a little bit. I mean, I get emails from the college, so I know I got an email to say that they were asking for feedback on the plan to include effective referrals, which I think is currently only required in Ontario, New Brunswick, and BC. And then all of a sudden, actually, thanks to the Dying with Dignity media sort of daily updates that I get, I learned yesterday from one of the newspapers that it had been dropped. So I actually can't speak to more. I mean, as to why it was dropped. Obviously, the political climate is not one of hugely pro-MAID. So, and certainly, I believe our government has a lot of focus and puts a lot of priority on religious freedom, and that tends to be where MAID and sort of conscientious objection butt heads. And a lot of people do view this whole issue of effective referral as sort of forcing a conscientious objector to be more involved with the process than they're comfortable with. So I would imagine that somewhere in that milieu, it was dropped. But yeah, it seems to no longer be planned anymore.
Okay, thank you for that. This one is we're actually gonna ask to both of you because I think you both work in separate cities, so this would be a good question for each of you. So from each of your perspectives as healthcare providers in both Edmonton and Calgary and surrounding areas, what would you say is the greatest setback in accessing MAID in Alberta?
So yeah, go for it, Peter. I'll
Sure.
answer after.
Again, I kind of touched upon this already, the availability of assessors and providers in certain regions. I'm certain that Calgary has plenty now. Sounds like Red Deer has plenty. Edmonton, we're very well stocked with the navigators did a great job at cultivating assessor and provider resources all over. The North Zone is still so anything north of Edmonton is hurting. Like I do almost weekly road trips to Barrhead, to the point where I know exactly that from my house to Barrhead Hospital is an hour and 14 minutes and 128 kilometers. So the biggest barrier I feel is assessors, providers in rural Alberta. And the next question would be why? And it has to do with, it's a multifactorial question. It has to do with the fact how it's the different demographics, if you will, a bit of a Bible Belt. but also has to do with how, and I hate to go into the financial aspect of it, but it is not well reimbursed for physicians to do rural calls and long calls. It's much more affordable and reasonable for nurse practitioners, because I'm not sure if you guys know, but physicians are reimbursed way differently than nurse practitioners. Nurse practitioners were employees, physicians, mainly speaking, they're independent contractors. So the why is multifaceted, and it's well beyond the scope of this forum.
Thank you. I don't know, Hayden, if you have anything to add to
Yeah,
that.
you know, I agree in large part with Peter. I actually think Alberta, certainly from what I read on forums and whatnot, Alberta, we are actually very well set up for MAID. Like our zone-centered coordination centers make it actually relatively easy to navigate the MAID process. So once somebody is aware of MAID and knows to submit a record of request, once you're linked to the navigation service, they are actually excellent at helping navigate and coordinate the care. So, you know, other barriers, of course, include knowing that it exists, knowing where to get a record of request, making sure that somebody will help you with that. Again, fortunately, Alberta Health, if you sort of Google Alberta Health Services MAID, it's very easy to find an email address where you can get in touch and get more information. But yeah, so once you're connected, then the limiting factor is the number of assessors. I wish that we had more people who were willing to do the assessments, because, you know, if you have been following a patient for a long time, you already know most of the stuff you need to put into an assessment. It doesn't really need to take that much additional time. And then I would certainly agree with Peter that, you know, as somebody with a young family, for me to be asked to go and see someone in Brooks or Sundre or Medicine Hat or something like that, because we don't get reimbursed for our travel time, you know, it's time away from our kids or my kids. And so that does make it more challenging in outlying communities where there may be fewer assessors and hesitancy amongst the local medical folk to do the assessments.
Peter, I'm not sure, you unmuted there if you wanted to add something else.
Just since Hayden brought up navigation, I'm involved in, and same with Hayden, with national organizations. I go to conferences, have workshops and meetings with people and MAID providers and assessors and navigators across the country. And one thing is an absolute without dispute across Canada, that our navigation system in Alberta is second to none. So whatever grievances Hayden and I may have with Alberta Health Services and how we do things and how we not do things, the navigation system was set up extremely well, and it's ran flawlessly. Mainly tiny little glitches, almost never because of navigation, and it's we have a really good system. Like Hayden said, once your name and your query is known to the navigation system, the process is flawless.
Yeah. In fact, just to that effect, Peter, I think it was you and I, like we even shared a patient across zones. You know, one benefit that came out of COVID, dare I even say it, but the advancement of virtual care. So we had a MAID colleague in a different province who sort of needed help with MAID taking place in Alberta, connected Peter and I across provinces and virtual care and the navigators, and we were able to make it happen. But it was because we had this central coordination center that was able to just smoothly bring everything together. So there's no better, well, while our numbers may be in the bottom 3 of the provinces, I truly believe I wouldn't want to be trying to pursue MAID in a different province if I needed
Absolutely.
it. So.
And even like Ontario, you would figure that Ontario would be so advanced, and so they have like I think 23 different health regions. They have 23 different ways of doing things. None of the EMRs talk to one another. None of the health informations are linked when. We have areas like large population, like million and a half plus areas of Ontario, that their navigation system, and I swear I'm telling the truth, their navigation system is a bunch of docs and nurse practitioners on a WhatsApp group. And that is their navigation system. So we have it good here in Alberta on that aspect.
Yeah.
Yeah, it sounds like once you're connected to the proper channels, it's relatively smooth sailing from there. So that's really good to hear. Just on that note, you both kind of made comments about this, but is there a public list of MAID providers in Alberta that exists, or do they have to go through the navigation team? Some people are just interested in knowing that.
If you notice,
Yeah,
both
so
I shook our heads very honestly. It has to do with privacy concerns.
yeah. That said, if you are working with someone in a medical setting, and and they disclose, or it's through the means of the conversation, the patient expresses an interest in MAID, I can help that person with the process, and I can work on their assessment. So you don't have to be referred through the coordination center. But that's the most likely case, because again, unless you're working with someone the patient says, I'm interested in MAID, and I say, oh, well, I can help you put in the record of request and do your assessment. The only way you're going to be connected to an assessor is through the coordination center. Yeah.
Right. So we do know that you do, like you're saying, you do either need to go through a healthcare provider and speak to them and say, hey, this is something I'd like, and then see if your provider would like to be an assessor, or through care coordination or AHS in this situation. So that's good to know. And then somebody else was wondering, I think Hayden, you touched on this, but can a MAID assessment be done online with a caregiver in attendance?
Yeah, so even without a caregiver in attendance, I mean, I've done a small handful of virtual assessments. I ask for some confirmation that, the person I'm seeing is who they are. So, they can hold up a driver's license or something like that. By far and away, my preference is to do it through a video conference, whether it's Zoom, FaceTime, WhatsApp, Facebook Messenger, like whatever the case may be, something with a camera. But there was a case where a patient did not have that technology available, was in a very rural and remote location with limited mobility. And so we sort of contracted and agreed, like, tell me your PHN, your date of birth, the simple demographics. We said, okay, like, we'll move forward with the assessment. Of course, if they move forward with the provision, you'd of course be seeing them face to face. And I think it would be quite a shock to get to that point and discover, oh my gosh, like, you've been impersonating someone else. I don't imagine that would happen, but through the assessment process, it can be done virtually. And of course, when it comes to the provision, that will be in person.
Exactly. In my practice is definitely at minimum video conference. There's been a few cases where, again, technology, rural Alberta, and being elderly enough that not being able to navigate technology. And that usually buys a nurse practitioner like myself or one of my other colleagues a lengthy road trip. I would And I'm probably more on the conservative side. I would just not feel comfortable, even with a bunch of safeguards around, to have an assessment not seeing the patient. So never by phone.
Yeah, that's good to know. You definitely want to see that person face to face, just on that standpoint of wanting to be more relational and understanding. You want to kind of see that person and connect on that standpoint. So okay, we have a couple more questions. Yes, let's see if we can get through a couple more. So in 2022 in Alberta, 64 people had forced transfers for MAID, meaning they had to be removed from the facility they were in to have MAID because their facility wouldn't allow MAID. In the region where you work, has it ever been difficult to find venues for these people to have MAID? Somebody's asking.
So I can say in Calgary, we are fortunate that, well, I mean, by and large, MAID is provided in a, I guess you could say 4 places, either in hospital, in someone's home, or in some kind of like really public facility outside of that. So that's either a long-term care or a hospice. And I think it's, as a general rule, if any of those facilities, obviously not their home, but if any of those public facilities are under a faith-based banner, MAID is not allowed. So I don't work with a lot of people in long-term care, but I work with a lot of people going to hospice. And of the 7 hospices we have in Calgary, 2 of them are under sort of a faith-based banner. And so it becomes quite an important discussion when somebody's sort of saying, I want the option of MAID, but I think I want to go to hospice for a while. Because we know that if they go to one of those 2 hospices and then decide they want to get MAID, they won't be able to get it on hand. So then we're talking about a transfer to a different location, and they really need to decide, would they be willing to go through another transfer, or would they rather go to a different hospice altogether where they could, have their provision on site. What's become increasingly challenging over time is, we had one hospice that sort of with open arms kind of said, we will receive people here to have a MAID provision. If they don't want to do it at home, they're not admitted to hospital, or they're in a faith-based institution. But beds fill up, and so there can be an increasing delay to the availability of a bed. And especially if the transport has to happen by ambulance, if it's not going by private vehicle, well, when you're trying to transport people by ambulance in today's system, where ambulances can be delayed by 4 or 5 hours, it becomes a significant problem. And that was one of the key things when we were talking about providing MAID at the Red Deer Hospice. They were having to transfer from the Red Deer Hospice back to the hospital, where the hospital had no beds and there were no ambulances. So families are preparing for MAID on Saturday at 9 a.m. Well, if the ambulance doesn't show up until 1 p.m., it puts a lot of people in a lot of distress. So forced transfers are a huge problem. Fortunately, because none of the hospitals in Calgary are faith-based, we're okay from a hospital standpoint. Most of the hospices are okay, but it's an important consideration.
Yeah, so we are not as fortunate in Edmonton. In fact, half our hospitals in Edmonton proper are faith-based. So the Greenlands Hospital and the Misericordia Community Hospital. So I am very familiar with forced transfers. In fact, probably you guys know already, but Dying with Dignity Canada, the ending of forced transfers is a top priority for the organization, as it should be. So the way we deal with it, because we are dealing with it almost daily, is that we have 2 dedicated areas that we can use. One in the Norwood facility, and one in the Sherwood Park Urgent Care Center, that we can use those facilities after hours for forced transfers. And we use them, like I said, daily, if not daily, several times a week. And it's probably definitely on my #1 list of wanting things to change. Forced transfers are terrible. You're uprooting a patient who is at the end of their life, and now they have to get into an ambulance and be transferred into a very clinical, very cold, foreign facility to have their last moments. I can't think of many things that are worse than that. We do our best to make it as good as possible, but certainly it needs to end. And Dying with Dignity Canada is working on it on multiple fronts, and hopefully at some point forced transfers will be a thing of the past. Hats off to British Columbia, though, and I know Hayden did his at least your residency there. So several faith-based organizations now have they realize that it is the wrong thing to do, so they've kind of gotten around it by dedicating one room in their facility as they kind of just renamed it or reclassified it, and they classified it as not part of their facility. So that room is not part of the faith-based facility. So people can actually have medical assistance in dying. In some of these, I believe they're mainly palliative care and extended care facilities.
Thank you for that. And as you mentioned, it sounds like forced transfers are on your radar, on Hayden's radar, definitely on Dying with Dignity Canada's, and it should be on everybody that's tuning in as well. Let me just see. Okay, we have time for one more quick question. Maybe let's see, Hayden, if you want to answer this one. If someone is planning to donate organs, do they need to have MAID in a hospital in Alberta? I've heard that some provinces people can die at home and still donate. This is a question from the audience member.
Mm-hmm. Yeah, if they want to donate organs, right? Like, yeah. So yeah, for sure, if somebody wanted to donate organs, yeah, actually, Peter, you probably know better. Yeah, working in ICU with DCDs, yeah.
It's not from ICU so much, but because I've been doing provisions for so long. So the only thing we can do is, this is again a bit of an extended scope to this conversation, but there's two ways of donating organs. One is the traditional way of donating organs, where a person who is in ICU and they're declared brain dead, they can donate their organs as a traditional organ donation. Then there's something else, and it's called DCD, as Hayden let it out of the bag again. So donation after cardiac death. Now, these are very special circumstance organ transplant or organ retrievals, if you will. I apologize for using such technical term. But anyway, in these cases, patients that are not deemed brain dead, but they are dying from one disease or another, they can donate their blood. And these are usually traumatic brain injured patients in ICU that have healthy organs, but their brain is so damaged beyond repair that they would be in a vegetative state forever, and they would not be able to have a meaningful life. So they can donate via donation after cardiac death, and essentially what that is being taken off life support, and when the heart stops, and the heart stops for a prescribed length of time, then they can be taken out of the patient. Now, that is exactly what we can do with patients undergoing MAID if they meet certain criteria. And I don't want to go through the criteria, but essentially, it has to be that their organs are suitable for someone to receive them. So they don't have metastatic cancer, they don't have
infectious diseases, prion diseases. Yeah,
exactly. So I have done now 4 of these cases where we do donation after cardiac death. Now they do have to be at the hospital. There's no other way to do this than in a hospital, because when the patient goes through medical assistance in dying, they have a very short period of time from that cardiac death to go to the surgical theater, to operations, to have those organs removed. So if this happened at home, there would be such an extended period of time that this could just not happen logistically. So I think if someone said that they had patients that donated organs and they were at home, perhaps maybe they were tissue. So they donated tissue like bone and ligaments and cornea. I don't know how that works, but that is the only possibility I can see. Certainly to donate proper organs like kidneys, liver, heart, lung, this needs to happen in a hospital.
Okay, thank you so much for that. It can get really tricky when it comes to organ donation. So we usually refer people to their clinician to ask these questions, but thank you for clarifying that as well as clinicians ourselves. So that's all the time we have for today. Apologies, we went over a couple minutes. Thank you so much for everybody for tuning in today. Thank you so much for Peter and Hayden for answering all of our questions. Apologies on not getting to everybody's questions, but again, you can always email us at support@dyingwithdignity.ca and we can get back to you. Again, thank you so much to everybody who tuned in today. Thank you, Peter and Hayden. Have a wonderful rest of your day and keep warm.
Thank you. Take care, everyone.
Take care, everybody. Bye.